Okay, so welcome everyone to the Older Adult Behavioral Health Initiatives training. What's going on with my client, working with depressed and deactivated older adults, presented by our amazing Nirmala Dhar. This is from Jackson County and Josephine County, and we have a few training etiquettes. Please keep your mics muted. We will allow you to talk within this webinar, but we are asking you to utilize the Q&A box for questions and comments. The slides are going to be available to you. We're recording this to post it onto our OABHI YouTube channel. And to receive the CEUs, live attendance is required. So we will be tracking everyone's attendance, and those who are here the whole time will be able to get those CEUs. We will be sending you a follow-up email with a Oregon NASW CEU survey and a survey from PSU. There are the folks who track our trainings, and it's really great for us to see what you've learned, topics of future interest for trainings, and any suggestions and comments. We want to let you know that the Oregon Behavioral Health Initiative started in 2015, and we have 24 specialists across the state, and we all work in collaboration and coordination in different systems of care. We're located within a county mental health or the area agency on aging. And we work to build capacity in our workforces and our community. And we provide complex care consultations. And this is all to improve the access to behavioral health services and health and wellness of older adults and adults with physical disabilities. We have 2 upcoming trainings that we want to let you know about. We have a geriatric competency series, and we have Dr. Drago that's going to talk about chronic pain and medication misuse among older adults. And then Nirmala will be returning to do a presentation on PTSD in older adults in June. Okay, so I'm going to let Angela Jensen do our introduction for Nirmala, and I'm gonna stop share. Okay.
Thank you for that. Well, if you have not heard one of Nirmala's trainings before today, you are in for a treat. Nirmala has over 35 years of experience as a licensed clinical social worker and in the field of mental health. Many of those years spent in the world of gerontology and gero. She is a content expert. She is a sought-after speaker around the state and nationally. We are lucky to have her. She comes to us through Oregon Health Authority's Division of Behavioral Health, and she is our Older Adult Behavioral Health Initiatives Project Director. So we work closely with Nirmala and rely on her for her expertise. Nirmala, I know you want every moment to be able to interact with folks and get the information out there that we need to hear. So I am going to turn the microphone over to you, and we will cue halfway through so everybody knows that we're on track time-wise.
I think, Angela, there was a poll.
I'm so sorry. We're supposed to launch a poll. It's live. Okay, so does everybody see the poll?
Yes, we see it.
Not just me. Excellent.
I see it.
This helps Nirmala know who her audience is, and also what you might bring to the table around the topic of deactivated, demotivated older adults. It is a very niche topic. There are specific evidence-based screenings and also interventions. So Helps us all to know. Helps us all to know. I'm sorry, this is fascinating to me. I'm getting caught up in reading the poll. Okay.
And if I'm not mistaken, they need to scroll to the bottom. There are like maybe 4 questions. So
Q, yes. If
5,
you have
sorry, 5
trouble
questions.
ending the poll, it's because you haven't seen and answered all the questions. So you have to scroll. And it's looking like a few folks are still hanging out there. If you just joined us, please take a moment to look at the poll. Should be displayed prominently on your screen. We got a lot of Jackson County people. Yay, Jackson County. We got a lot of people that work with depressive adults. Okay. Well, I would say most everybody's had a chance to weigh in by now. So shall we end this poll? Speak now.
Yes, please do it. It's 9:10. So I'd love to see. Okay, wow. Where did it go? Where did the results go?
Share results.
Yes, please.
It says I am sharing results. So we have 85% of folks say that they work regularly with depressed older adults. We have 64% say sometimes they feel effective in addressing and supporting, 24% say very often, and 12% say not at all, or no at all, sorry. Within the last 12 months, have you taken a training? 78% said no. And professional roles, the majority are case managers, a few social workers. We have a peer support, a community health worker, a few supervisors, and 5 people said other. So if you wanted to put into the chat what your other role is, that would be great. And then the majority are from Jackson County, some from Josephine, and 1 person from Curry, and 1 person from another county in Oregon.
Thank you so much. Kudos to Jackson County for this great turnout, and to Josephine County. So thank you for inviting me back. I think I've presented several times. So next time, maybe Angela's, you may not need to do the introduction, but I'm delighted to be here. And this subject is near and dear to my heart. What I want to just highlight is this is the 1st of May, and May is recognized as Mental Health Awareness Month. This consortium of OABHI specialists from Jackson and County are bringing you this training as part of of Mental Health Awareness Month. And tomorrow is a very special event. It is the older adult mental health awareness day. And I'm wondering, Angela, or if you all can put a link, if anyone still wants to attend the virtual event that is going to be hosted from, I think from Washington, D.C. I would urge you all to attend. And if you are a large group, say at a community mental health program, to actually see the event together on a large screen. It is well worth your time with some great topics, and CEUs are offered. So welcome to Mental Health Awareness Month. My challenge to you is, as you go back to your places of work, wherever you work, to actually make that kind of your mission for this month, to raise awareness of mental health wherever you are. It is still highly stigmatized. People don't talk about it. So if there is any way that you can get the word out in your communities that mental health is health, that you would be doing a great service to all the people who suffer in silence. So thank you again. And I am going to go ahead now and share my screen. I looked at some of the names. And let me tell you, Susan, it's always a pleasure to see your name. So I feel a little bit at home. Oh my, I recognize one name. I did recognize some others too. So thank you all for being here. And my topic today is, why won't my client do anything? I've worked in community mental health for most of my professional career, whether it was in Oregon or in New Jersey. And I used to feel this way, why I'm doing everything, but nothing's happening, or they keep coming back, or they're here for many years. And so I'm sure you have asked that question yourself. And so my learning objectives are really for you to better understand depression in older adults and what may be contributing to them being behaviorally deactivated. Many of you, I think when Angela Franklin read the poll, I think she said like 85% of you work in some capacity with older adults. You may be able to identify some interventions that can mitigate depression and increase activation. You can help maybe identify activities that connect to your client's values, and we're going to talk about it. And then, you will talk about some screening tools. So I'm sure, like I said, we have all asked this question. I did, certainly. Why is my client stuck? Is it something that I'm doing? What's happening with my client? And what happens is it evokes very strong feelings in all of us, correct? Frustration, sense of failure. We all got into this profession to help people, correct? And so when you're feeling stuck, when you're feeling your client is stuck, you kind of start to doubt, hey, am I a good professional? Doubt. What am I doing? Am I doing it right? What have I missed? Anger. I'm just working on a complex case right now with some community partners where the staff are really angry and frustrated about one particular client. Burnout. We have mental health professionals have one of the highest rates of burnout, where they are just disenchanted, and want to leave the profession, or at least want to leave public mental health. And that constant lack of professional gratification, which gets diminished when you feel all of this, correct? When you feel burnt out, when you feel moral distress, when you have a sense of doubt or failure, that I'm not doing a good job. All of these feelings I have put here because I've experienced them. And I'm sure I'm just taking a leap of faith here that you have too, as individual professionals, paraprofessionals, and also as teams. So here are some characteristics of difficult clients. And, I just want to start by saying, I believe in a no label zone, right? It's very easy to label difficult clients, correct? But I just want to caution that that's not what I am, talking here. I'm just talking about what are some characteristics that make clients difficult, that make you dread seeing them on your calendar. In fact, I attended an ethics conference last week, and there was a complex case they were discussing in one of the sessions, and the presenter said, the minute they saw that client, almost everyone had a visceral reaction. Some would actually feel nauseous and want to throw up because it was so frustrating and difficult. So what are some characteristics? Lack ability for productively using insight, like insight into their own behavior. Failure to engage or adhere to treatment. Here you're giving, you're having therapy with them, assigning them homework, hoping they will go and practice skills, but apparently they're not. They cannot see their own role in the behavior. It's kind of like a blind spot. What they do is they blame everyone else on the team. They're very often unreasonable and demanding. They could be loud and insistent in the waiting room, or calling or sending emails, all of that. Or they could be avoidant. They're just not coming in and they're high risk. They frequently blame, deny, or accuse everyone else, in their life or on the team or the therapist or the professional. They become easily highly escalated. Before you know it, there is loud voice screaming. And I have seen all of this. So I put this together from my own experience too. And they create upset and distress around them on teams and clinics. And we see them as difficult. Does this sound familiar? If it does, I'd love for you to put something in the, I don't know whether it's chat or Q&A, wherever, but we'd love to see whether any of what I said sounds familiar to you. So with that, in that as the backdrop, why is my client stuck? Those were some of the reasons. My first few slides are going to be for you to understand depression in older adults better. Okay, so I love this. I love this diagram here. This this Venn chart of these three intersecting circles, which is biology, social, and culture, and psychology. Depression is impacted by the dynamic interplay between biological, social, cultural, and psychological variables. And this can't be more true for older adults in particular. I would say across the lifespan, but I think it has to be emphasized even more for older adults for a variety of reasons. Interventions to be considered, and this is kind of like a cheat sheet, that could be considered are medical workup and rule outs, and you'll see why in a little while. Substance use assessment and treatment, exercise and movement, medication, sleep restoration, psychotherapy, health and behavior interventions, group therapy, and right at the bottom, can you see they're color coded? So they kind of correspond to the three colors in the three circles there. And then housing, transportation, relational needs, spiritual support, volunteering. So I would highly recommend you to download this if you want like a cheat sheet on what should I be doing or what is depression for older adults. And I would argue for across the lifespan. Here is the DSM-5 criteria, and I'm not really going to go in depth over this. Suffices to say that, there are that you have to have 5 or more of these symptoms present during the same 2 weeks, with the first two have to be present. Depressed mood most of the day, nearly every day, and diminished interest or pleasure in almost all activities. Now keep that in mind. And then you can see the rest: weight loss, gain, hyper and hypo, sleep problems, all of that. So you will be getting this slide deck, but I just wanted to let you know what is the actual clinical diagnostic criteria. And then, with the publication of the DSM-5-TR, they have like expanded the different kinds of depressions. Many of us are very familiar with major depressive disorder. Sometimes you see the acronym MDD, but there are many others. Persistent depressive disorder. It used to be called dysthymia, prior to DSM-5. It was kind of that low grade, more like mild depression, which is chronic.
Nirmala, can I interrupt you for a second?
Yes.
At least one of our participants is having trouble seeing slides. Can we get folks to weigh in the chat? Is everybody seeing the PowerPoint? Or are you not seeing the PowerPoint? And can you put that in the chat feature? Because I've had somebody tell me that's not working for them. So
Angela, the chat is not working for me, and I can see the slides fine.
Okay,
I can too, but it says chat disabled.
Yeah, my
Okay.
chat's disabled, but I can see it good.
The chat's not working for me either.
Okay, so it looks like for most people, maybe one of you can work with the other person who cannot see the slides.
Okay.
So some newer ones were
Mhm.
premenstrual dysphoric disorder. Then look at the others: substance and medication-induced depression. Of
She
course, we
just
all.
doesn't care.
Could you please mute yourself? Yes. Postpartum depression. We all know, adjustment disorder with depressed mood. So you can see depression, a depressive disorder due to another medical condition, such as stroke, Huntington's, TBI. So these are all, and they re-entered a prolonged grief disorder. It was removed earlier, but in DSM-5-TR, they have reintroduced a prolonged grief disorder. So these are all the different kinds of depression that you would classify when you are doing your assessment. So with that said, how is it different with older adults? Older adults, and I'm talking about this current cohort of older adults, often present with non-specific physical symptoms when they're depressed: fatigue, aches and pains, gastrointestinal distress, sometimes with plain hypochondriasis. Impairments in cognitive abilities will be marked and dominate the picture, such as, they have problems with concentration and memory. That's why it sometimes gets misdiagnosed as dementia. Older adults are less likely to say, I'm depressed. One reason is that, the current cohort's mental health literacy is much lower than younger cohorts, because they didn't grow up in an era where people talked about mental health and depression. And so it continues to be very stigmatized. They would rather say, I'm feeling stressed or I have concern, but they will not say I'm depressed. So, and then how do you recognize that? How do you all said majority of you are working with older adults. So what we say is older adults experience depression without sadness. Remember that first criteria: sad mood for 2 weeks consistently. What they actually manifest is what we call anhedonia, the second symptom. Anhedonia, which is loss of pleasure, which is prominent in older adults. And these somatic complaints: fatigue, apathy, just general malaise, there's no kind of medical reason for it. So again, I want to point out, it is anhedonia, or loss of pleasure, or I don't do the things I used to enjoy. I'm not engaging in my hobbies. I just sit all day. I'm apathetic. I lay in bed. That is what dominates the picture, clinical picture in older adults. Not that I'm crying and I'm sad all that. And they'll certainly not say that. So what are their symptoms? Like lack of vigor and withdrawal, which are referred to as second core symptoms of major depression, are usually very pronounced in older adults. That is that loss of interest. Since older adults tend to be more apathetic or have apathy in their presentation. And that suicidal ideation is very frequent in late life depression, together with anxiety, especially in the morning. And why am I saying especially in the morning? Do you know that there is a diurnal swing in mood disorders? That mood disorders sometimes improve as the day progresses. So we actually asked that question, so it's diurnal swing. So you see it worse in the morning, slightly better in the afternoon. So they tend to be like worse with anxiety and all of that early in the morning. And then the second thing, the other big difference, they are at higher risk of experiencing psychotic symptoms with depression, older adults, which you will not see it, in younger adults, like at the numbers that are suggested, with delusions present in 45% of older adults admitted to the hospital, like a psych hospital. So they have more psychotic symptoms. So remember, we qualify it as major depression disorder with psychotic symptoms. Most common psychotic symptoms manifested are auditory hallucinations. Often these are derogatory comments that are, just constantly playing in their head. Paranoia, they're absolutely paranoid, and nihilistic delusions. So these are like the major differences in depression presentation, and therefore it becomes important for all of you, 85% of you, or all of you. How do you recognize depression in older? And it can be missed if they are not endorsing, hey, I'm really sad, which they don't. And then there is a second confounding factor. Depression is entangled in a bi-directional relationship with somatic morbidity, which essentially means with medical diagnoses, finally resulting in an increase in your patient's or client's burden of disability and frailty, and actually it augments the possibility of death, because essentially what it says is depression co-occurs with a multitude of medical conditions in older adults. In fact, besides being a risk factor and a predictor of poor prognosis for many conditions like diabetes, cancer, cardiovascular disease, dementia, depression can be precipitated and perpetuated by chronic medical conditions typical of the aging process. So first, they co-occur more frequently than not with medical conditions. Look at it, diabetes. How many of you who work, 85% said, screen your person with diabetes for depression? Cardiovascular disease. Do you know having untreated depression or having depression is the single biggest independent variable for death in cardiovascular disease, or if you've had a heart attack, is depression. That you will die within 1 year if depression is not actively or aggressively treated in someone who has had what we call a myocardial infarct. High levels with cancer and dementia. So one is it co-occurs, and the second is it actually is a risk factor. Any of these medical conditions is a risk factor for actually you developing a depression, which is not the case in younger people. So if you are working with older adults who have multiple chronic conditions, which is very common in the United States, after age 65, people have 2, 3, 4 chronic conditions, you should be actively screening for depression. Okay. In addition to all what I said, depression affects executive functioning, which is required for high levels of independent living, like for our IADLs. What are these executive functions? They consist of your ability to plan, to have memory, to make decisions, to be motivated to complete tasks, to inhibit, impulses or thoughts so you can complete a task, to have mental flexibility, to actually begin a task and finish a task. That means persevere, to organize your day, to self-regulate yourself. Can you see why a person with depression may not be doing any of the things that you're asking them to do, because they are what we call behaviorally deactivated, because their executive functioning is affected. When we talk about, I feel apathetic, I feel I have no energy, I feel fatigued, I can't concentrate and remember. It's really code for executive function. I'm adding this in all my presentations now, whether it is on depression or otherwise. Hearing, your ability to hear, is a key variable in good quality of life in general, but it's a risk factor for depression and dementia. And the good news is hearing loss is a modifiable risk factor. So you should be asking yourself, do I routinely ask about hearing? Or do I recommend a hearing assessment? Or do I check to see whether my client's hearing aids or whatever device they're using are in working order? Because it is a reversible predictor of depression. In addition, hearing loss can mimic depression. Because what happens when you can't hear, you isolate yourself, you withdraw, you have less cognitive stimulation, you don't want to go into public places because you can't hear the conversation, you can't participate socially, and so you withdraw, and that leads to this kind of cycle of depression, which is something you will not do with younger people, correct? As part of your assessment, but it should absolutely be part of your assessment with an older adult presenting to you, or that you're working with in terms of depression. Okay. Look at what happens with depression and older adults if it is not recognized or treated. You have very worse health outcomes. You do very badly with hip fractures, with heart attacks. I already told you that, with cancer. In every way, your mortality or your death risk increases. I remember I said there's a tight bidirectional relationship with depression and medical comorbidities. So guess what? If you're not actively screening and treating depression, you actually increase the risk of that person dying. So can you see how important it is? And just a word about suicide. In Oregon and in our culture, we are very youth focused on suicide prevention, which is a good thing. But what I say is older adults have the highest suicide rate, not youth. And actually middle-aged adults overall have higher suicide rates than younger people. And across the lifespan, men are at higher risk than women. So here are I talk about the 5 Ds of suicide. This really comes out of the work of Dr. Cornell Yates from University of Rochester. He talks about, this is an easy way for you to remember, what are the risk factors? 5 Ds, depression, up there. Disease, and by disease, they mean disability, all of those comorbidities that I just spoke about. And like their functional impact on the person. Disconnection, which is that feeling of isolation and loneliness. Deadly means access to firearms and very often to medications, because they're on multiple medications. And then demography. It is generally males. I've already said across the lifespan, men are at higher risk for various reasons. And then for older adults, it is white males, especially much older, like 85 plus. And now there's a whole theory about what we call vascular depression, and which kind of predisposes or perpetuates something that we call geriatric depression syndrome. It's not in DSM-5, but it's a real thing. And the hypothesis is supported by a comorbidity of depression, that it co-occurs with all those diseases I just told you. Vascular disease And so it just ups your risk, and drugs used for prevention and treatment can actually reduce this risk. But this is a hypothesis, so it's not in DSM-5, but it's absolutely real. So I wanted to mention that to you, and I would encourage you to read more about vascular depression hypothesis. And here is a differential, which I'm not going to go over for time, but you will be getting my slide deck, and you are welcome to take a look at, like, what's the difference between the clinical features of vascular depression and clinical features of like regular depression in older adults. And you will see a lot of it is around this demotivation, behavioral inactivity. So, okay, a word about cross-cultural perspectives on depression. It's important to explore and compare beliefs about the nature and causes of depression, and to suggest ways in which these beliefs act to facilitate older adults from accessing treatment. For example, just the word depression. What does it mean to participants? For many older adults in this current cohort, depression was viewed as an illness arising from adverse personal and social circumstances. And so why am I bringing this up? That it is important to speak the language of depression when you're trying to screen and understand whether your client is depressed. If you're going to offer a group in the community saying, hey, come to my depression class, I'm going to go out on a limb, and I don't think I even need to go out on a limb, you'll have zero attendance. But if you were to say, hey, would you like to come and learn how to enjoy your hobbies again? How to connect with other people and feel satisfied? I bet you more people will come. Because you're not using that stigmatizing language, which is not currently in the lexicon of older adults. So, and that is the same with other racial and ethnic groups. And I do another training on depression where I really explore what are the idioms of distress that older adults use in different cultures. In the United States, and if you look at our DSM-5 criteria, we focus on both cognition and somatic symptoms. In our criteria, correct? We talk about mood and thinking, and we also talk about sleep and appetite. But in many countries outside of the Western world, they really talk about depression only in somatic terms, not in mood terms. They will say, I'm not feeling well, I have pains, I'm not feeling hungry. And mood is never even talked about. And so that is the predominant paradigm in non-Western countries. And there's lots of research if you want to look it up. In my other presentation on depression, I talk a lot about, understanding idioms of distress between different cultures. So the lesson from what I'm saying is culturally appropriate inquiries about recent life events can facilitate discussion about depression using culturally appropriate terms. Absolutely. So using the language of depression used by whether it is your specific minority group or with mainstream older adults in the dominant culture. Absolutely important for you to know that. So in plain English, what is depression? For older adults, it can be social withdrawal, overwhelming guilt, sense of worthlessness, dismal hopelessness, doleful ruminations, loss of appetite and sleep, and then injurious behavior to end life. It doesn't look like a great prescription for well-being, correct? Because this is the lived experience of people with depression who are older. And, I would argue also with younger people. So what keeps depression going? And why do our clients get stuck? What do you do when you feel unmotivated? When you're depressed, you feel less motivated to do the things you enjoy or spend time with people you like. Without feelings of motivation, it is often easier to avoid doing things, correct? Because you don't have motivation. Following the demotivated feeling and avoiding these activities means that you're missing out on key ingredients of well-being, making you feel even less energetic and even more demotivated, and I would argue even more guilty and worthless. And remember, I talked about executive functions, where one of the key areas is task initiation. That means you're able to get up, start a task, and persevere with the task. That you are so organized that you've planned. Now set that in the context of what I just said. When that is impaired, how are you going to feel motivated, correct? And then the second piece is unhelpful thinking habits. All of us have automatic thoughts, you and me, whether we have depression or not, that just pop up in our heads. When you're depressed, your thinking can become distorted or biased without you also realizing it. It's like so subtle, the change. It is like your mind starts taking unhelpful shortcuts with thinking. This causes your thinking to become negative, self-critical, leaving you feel hopeless. You know, I give a whole training on taming the chatter in your head. And that is what people with depression experience, this constant chatter of negative, self-critical, voice in your head. So that's what keeps depression going, these two things. Then add to that ruminating or worrying about your problems. People who are depressed try to solve problems by asking themselves questions like, why is my life like this? Why does my life suck? Why does it always happen to me? What is wrong with me? That's rumination, okay? Psychologists have found that particular types of thinking can keep people stuck in depression. Asking questions like, why am I feeling this way, tends to be less helpful than asking, what can I do right now that will help me? So rumination is the third thing. And then the fourth thing is your past beliefs, rules, and assumptions. People struggle with depression, often believe very negative things about themselves. For example, I'm a failure. I'm no good. I'm unlovable. I'm fat and ugly. These beliefs haven't come from nowhere. You can think of them as answers to the question, what has life taught me about myself? The problem is that despite these beliefs not being accurate or fair, they have profound effects on how you feel. So here are the reasons for why people get stuck. What you do when you feel unmotivated, unhelpful thinking habits, ruminating and worrying, and your past beliefs, rules, assumptions. So what is this rumination? Because, many of us who work with older adults or with adults in general forget to address rumination and avoidance as key factors in depression. So depressed people almost think about misery, of how miserable their life is. They mull over those events. And what they do is they just mull over it and don't really problem solve. And this word rumination really refers to animals such as cows who store their food partially digested in a special stomach called a rumen. And what do cows do? They regurgitate that food, chew on it later, and then digest it. So this word really comes from that special stomach, rumen, where basically people who are depressed keep regurgitating the same questions. Why am I so bad? Why am I a failure? Why am I so miserable? And this constant rehashing or regurgitating feed and prolong depression. And what does rumination do? It leads to withdrawal, inactivity, and more rumination. And all the research says, the function of this rumination is really escape or avoidance. That I'll just escape, I won't do anything. So really, it's very dangerous. And how many of you address rumination in your assessments or work? Because ruminations impairs your ability to problem solve. Even if you come up with a solution, doubt will creep in and will prevent you from carrying it out. And this rumination really impacts your social support network, whether it is partners, caregivers, family members. My gosh, this person is stuck. He or she doesn't do anything. And we offered this depression treatment called Pearls. The OABHI offers it, and I also know the RV-COG offers it. And believe it or not, they are addressing rumination and problem solving in Pearls. That means we teach older adults how to problem solve and get unstuck. Because that's what depression does, and that's what rumination does. Please check with Angela Franklin, Angela Jensen, Janine, and others on this Susan J. Rounds, where Pearls is being offered. Because I would highly recommend that you'll talk to them to see if Pearls could be something that you could be offering it at your clinic or your community. And so remember, I said the purpose of rumination is avoidance or escape. Depressed individuals tend to substitute behaviors that provide immediate relief for behaviors that cause long-term discomfort. For example, you will avoid contact with your social community by staying in bed all day. A function is to avoid exposure to situations which may be very kind of stressful for you. And so you feel some relief. But long-term, you're not solving any problem. So can you see how it helps you avoid and escape short-term stress, adverse thoughts, adverse situations? But long-term, you're not helping yourself. So this is the triangle of depression. Any of you who are therapists or who are not therapists, by the way, anyone can use this. It really comes out of the work of Aaron Beck, and now continued by his daughter Judith Beck out of the University of Pennsylvania. That's where cognitive behavioral therapy was born. Basically, this is the triangle of depression. Thoughts create feelings. Feelings create behaviors. Behaviors enforce thoughts. You begin with the thought, I'm unlovable. What is the feelings? Gosh, nobody would love me. They create behaviors. I'm not going to go out. I'm not going to go to my regular activities. I'm not going to meet that person. And that is a vicious cycle. It keeps repeating itself. This is just another way, this is out of UK, where they've added also like physiological feelings. So you have thoughts like, nobody likes me. I always mess up things. Feelings, you feel sad, you feel anxious, you feel self-conscious. What happens to your body? You feel tense, your heart races, you feel fatigued. And before you know it, your behavior is you withdraw, you don't answer the phone, you stop going out and socializing with your friends. And that whole circle goes, repeats over and over again till it is like firmly entrenched in your life. And by the way, you can use this and have your client put in their particular thoughts, feelings, body sensations, and behavior. So what does CBT do? And by the way, Pearls, that program that I talked about is really derived from cognitive behavioral therapy. So what does CBT do? It looks at the situation you are on, how you are thinking about it, what you are doing about it, what are your body responses, and what are your feelings and emotions. So I can't tell you how important psychoeducation is in general. We call it in our OABHI health and wellness promotion, but it's really imparting education and emotional wellness. And how about giving psychoeducation on automatic thoughts? You're teaching this. Automatic thoughts are about those which spring spontaneously in your mind in the form of words or images. They are often on the sidelines of awareness. And with practice, we can become more focused on them. In a life and death situation, it could be good to make quick decisions. One example is making a quick judgment. Is this good or bad? By the way, automatic thoughts are not always accurate. Just because you think something doesn't make it true. And they're often inaccurate in characteristic ways. One common type of bias in automatic thoughts is called extreme, binary, or polarized, or all or nothing ways. I am a failure. I am no good. I am unlovable. Can you see it is extreme and binary? Binary means black and white, yes or no. Signs that all or nothing thoughts are present included polarized words like perfect, failure, always, never, terrible. If any of those words are in your automatic thoughts, it is binary, polarized, and extreme. So teaching your client about this is just psychoeducation. And here are the 10 common errors which people with depression use all the time. And many of us who are not depressed also may be using it, but have learned to cope with it. I'm not going to go over everything, but we were just talking about all or nothing thinking, or black or white. You either succeed or fail. There's nothing in between. I'm a total failure. Nobody loves me. Mental filter. You always have this kind of negative mental filter. You see the world through these black lenses. Overgeneralizations. I always make stupid mistakes. You made one mistake in one situation, and now you've generalized it to your entire life. Disqualifying the positive. Oh, they're just being nice to me. There's nothing good about me. That you can't take a compliment, because deep down you don't feel you're worth it. Jumping to conclusions. There are so many other. Magnification and minimization. Emotional reasoning. We call these thinking mistakes or thinking errors. Should statements. I should be doing this. I should be a good daughter. Labeling and mislabeling. Personalization, taking everything personally as a self-blame. Even world events, you will bring it down to yourself. So really your role, whatever your role is, you'll have varied roles. This is a very nice little handout to print. And this is called ANTS, which stands for automatic negative thoughts. And you are really teaching your client to challenge those. Look at one of the little clouds there. Is there another way of looking at this? Is this thought helpful to you? What evidence do you have for this thought? How would someone else see this? What advice would you give your friend if they were having this thought? Is this a fact or just an opinion in your head? So this is one way of questioning or challenging those automatic thoughts, which are common, absolutely common in depression. And I'm not going to go over every slide, but there's something called attribution error in psychology. This means if something goes wrong and that makes you think negatively about yourself, you think the negative thought is true about lots of other things in your life, and it's going to be true forever. That's called attribution error. Error. For example, if your boss calls you stupid for making a mistake, you think, I'm a stupid person. Everyone will think I'm stupid. While someone with high self-esteem might think that was a stupid mistake, but normally I'm good at my job and my boss likes to bully people, so I'm not going to take that personally. But if you are depressed or you have that kind of attribution error, you're going to think, I am stupid. I'm stupid, stupid, stupid. So really providing these education, I can't emphasize it more. And it could be in a group setting. It could be emotional health and wellness class that you're giving at a senior center or at a community mental health program. The automatic thoughts are not facts. Did you know that just having a thought does not mean it's true or that you have to believe it? And here are some other things you can do in that class: exploring causes for and changes in beliefs, exploring the consequences. I love that. What are the consequences of believing that so strongly? If you had a friend who didn't believe that so strongly, how would they react in a similar situation? And then considering what it would take for that belief to change. What would it take for you to shift that belief? If you had to shift that, what new information would you need? And these are all skills that you're teaching in a psychoeducation format. So how can you help your client who's stuck with their thinking errors? Turn your ants, which is automatic negative thoughts, into pets, positive, empowering thoughts. None of us like ants in our home, correct? But we love our pets, dogs, cats, parrots. So how do you change that? So here are some tips I'm giving you. You're telling your client or your group, take the next step. Your brain thinks predominantly negative thoughts for a good reason, to keep you safe. However, these negative thoughts can also become a bad habit. What are we doing? We are encasing it in this scaffolding of habit. This is a habit that no longer serves you well. Notice your automatic thoughts and employ simple techniques to challenge and control them. It is well worth your time and effort. Turning off an unending flow of negative mental chatter is one of the best things you can do for your overall happiness and well-being. That's really the message you want to give your depressed client or your group. And we talk about these. Remember, I gave you the 10 or 12 errors. We talk about, in simple, plain English. Don't say cognitive errors, or just say unhelpful thinking styles. Catching automatic thoughts and reappraising these thoughts is a core component of traditional cognitive therapy. And I'm not going to go over every slide, but here's an example of black and white thinking, which is a very common error. So using polarized language such as, I have to be perfect, or I'm a failure, I always do this, I'm never good at anything. So this is like extreme polarized thinking. So people who habitually, and you're teaching this, people who habitually engage in all or nothing thinking may have blind spots for gray areas, situations where there are multiple competing explanations, but they hone in on the negative. Ambiguity. It may be very difficult for them to understand uncertainty and ambiguity. And they are less flexible. All or nothing thinking is common across a wide range of problems. Other problems, in mental health. Perfectionism, depression, we are all talking about, eating disorders, borderline personality disorder. Absolutely black and white, that inability to think in shades of gray. So the first step is to notice and label. You're teaching this. Actually telling them to practice self-monitoring of their thoughts and notice them and say, there's another all or nothing thought. I'm having an all or nothing thought again, even if they have to write it down. Then put your judgment on a scale. These are all skills that I'm sharing that I have used over the years. When you judge yourself in all or nothing terms, remind yourself that it doesn't have to be one or the other. Try putting your judgment on a scale. Total failure, good enough, complete. You actually maybe even build this little scale on a piece of paper and give it to them to kind of put a number to their judgment. Evaluate your thinking. Remember, there are lots of ways of judging any situation. Practice these. What would I say to a friend who was thinking like this? What's the evidence I have for this thought to be true? What's unhelpful about thinking this way? I mean, has it helped me for the last 20 years? What's a more helpful way to think about this? And really remember, these are skills, so it is practice, practice, practice. I used to teach this in my class, press the pause button on negative thoughts. We all have mental tapes in our head, and we tend to believe these narratives. What you should do, identify your errors, challenge them, because thoughts cause feelings, and then say to yourself, feelings are not facts. So pressing the pause button so that you do this. And you can even tell your client, hey, we need to practice to pause, to press the pause button. I'm going to let you take a look at this. This is some other ways that you can help them, identify their common cognitive errors or thinking errors. I love this. Remember, I told you I have a whole session on the chatter in your head. One good way is to stop and acknowledge. Stop. This is a negative thought. Question. Why am I thinking this way? What evidence do I have that supports this thought? Reframe. Can I reposition this issue and look at it as an opportunity? Act. Here's what I'll do. Reflect. What did I learn about my negative thought? Turning into a positive opportunity. I love this.
Nirmala,
Yes.
I want to let you know that it's 10:08.
Thank you.
Yeah.
Don't let negative and toxic people rent space in your head. Raise the rent and kick them out. Which is the negative talk in your head? How many of you have people living rent-free in your head? Rent-free in your head? This is a good strategy. Raise the rent and kick them out. So here are some other options for the same thing. Depression whispers bad things in your ears about your capabilities. You can't do anything right. You're a mess. You're ugly. Nobody loves you. Replace these words on your soundtrack with positive words and change your thoughts. In time, you will create new neural pathways. And the old pathways of thinking in the old way will actually wither and die and fall off, just like a branch of a tree that dies. And, I'm really focusing on this, eliminating negative self-talk. Here is what it looks like. I'll never get better. I'm not popular. They must hate me. I can't do anything. I'm not good enough. I used to teach my class, I used to say, turn down the volume. Turn down the volume on your critical self-talk. We all have an inner critic, whether we are depressed or not, all of us on this training. Listening to the critic is negotiable. I have an inner critic. How do I negotiate with that critic? I drown the voice, I turn the volume down. And here I was actually giving concrete pictures in my class, like a dog barking, you chain the dog. So as you walk away from the dog, because he can't follow you, the bark becomes less loud. That's how we need to practice to turn down the volume on our negative self-talk. Or every time you see yourself in the mirror, say something positive about yourself. Help your client carry flashcards to remind them of their positive traits. How can I help my client learn how to problem solve? Remember, I said executive function is impaired. People with depression tend to have thoughts that get stuck in their head, and they think about it over and over again. Help them identify what the problem is that the thought is telling them. Next, several solutions, and then help them to pick one action. And I'm just giving you the problem solving kind of skills here. Identify the problem, brainstorm and write down ideas, consider pros and cons, and then choose one possible solution. And by the way, Pearls teaches problem solving therapy. Then you plan, how you will carry out the activity, then you carry it out, then you review it, and then the goal is that you'll feel better because you achieved it, as opposed to just ruminating and going in circles. How can I help my client who is deactivated and has no energy to do anything? Did you know the less we do, the more depressed we become? The more depressed we are, the less we do. And that lack of interest and pleasure, remember that anhedonia that I talked about, results in more inactivity and socially isolating yourself. So what can you do for your client or in your group? Or in Pearls, that's what we do, behavioral activation. Increase engagement in activities that provide enjoyment or a sense of accomplishment. The mantra in behavioral activation is behave first, feel later, which is an outside-in approach, which means follow the plan for activities instead of thinking about how am I feeling. So even if you're feeling lousy, get up and do the plan. And then really, when you are helping clients look at what activities they're interested in, that they should be meaningful activities that connect to their values. Not something that is forced upon them, like in a long-term care situation. Hey, come to bingo. That may not be an activity that connects to their values. On the other hand, it could be because they want to socialize with others. I love this, and I know in Pearls we use this too. Look at the first graphic. Feel bad, do less. And it's a vicious cycle. What we want to break is feel better, do more. Do more, feel better. Can you see? It's absolutely simple. And I would love for you all to print this and use it with your clients or in your groups or just in promoting health and wellness in your community for older adults. Imagine doing a campaign on this, that everyone, you plaster this all over Josephine County and Jackson County. And it's really simple. It is difficult to, and perhaps putting this at the bottom of that, it is difficult to feel depressed and have low self-esteem if you are regularly engaging in activities that bring you a sense of pleasure and accomplishment. So here it is. Increase healthy behaviors, decrease depressed behaviors. Positive experiences result in improved moods and thoughts. And I put it really simple here. There's tons of science and evidence around this. And here is what I like. I call it the upward spiral of motivation. When you're depressed, you're at the bottom rung. You don't feel like doing anything. You have no motivation. You start doing something anyways. You join the Pearls group and they tell you, what are you going to do next week? So you start doing something. You feel a little better. You feel more motivated. You do more the next week. And pretty soon you're on your way to feeling better. So this is like the reverse spiral. And so behavioral activation really looks at promoting success, self-efficacy, which means I can do it, I'm capable, and self-esteem. And again, very important, this is a standalone thing which I'm recommending, identifying values. Values are what you want your life to be about, or how you want to live your life. They are statements about what's important to you. And they should really be about all areas of your life. So what's a valued life? Identify domains of valued living that are important to all of us, especially to older adults. Suggest how the domains influence our action over the past week. And then say, was this consistent with your values? So, we talk about values clarification. A lot of it is now, very much developed in this kind of therapy called acceptance and commitment therapy. If you're interested in knowing more about ACT, please go to, it's all over the place. You can get some more information on this, but for them, values clarification is central. But I'm using it just as a standalone intervention for older adults. Here are some areas of, areas that people most value: relationships, marriage, and intimate personal relationship, parenting or grandparenting, social life and friendships, professional life, maybe academic life, recreation and leisure is a big one, spirituality is a big one, community life, whether it is civic engagement or volunteering, self-care. So exploring what are your values and are you leading your life? Does your life align with your values? And, I love this question. What do you want to do? What do you want your life to be about? You're asking your older adults and yourself for that matter. Here are some questions that I've used over the years. Live your life on purpose. What matters to you? Who relies on you in terms of important to you? Who inspires you? Because that tells you a lot about who you are. What causes do you care about? Animals, animal cruelty, climate, environment. I'm just talking out loud. It could be any cause. Peace, world peace. That tells you a lot about who you are. Who are you grateful? What are you grateful for? What gets you up each day in the morning? By the way, when I was an intake therapist, that was a standard question I asked in my intake, my mental health intake. What gets you up out of bed each day? And how do you want to be remembered when you die? How will people remember you? So why are we doing this? Because we want to elicit a discrepancy by placing current behavior in the context of their values and desired future. Tell me about the times you're not living out your values as fully as you would like to. How does your current behavior fit in with your values? How can this value help you achieve your aim? How does your current behavior support the future goals that you've told me you want to achieve? And this could be absolutely done in a group setting too. And this could also be health and wellness promotion. What new behaviors will you try in order to head in a valued direction? Can you see? This is great psychoeducation too. Help your client define what their rich and meaningful life will look like. I have created in the past a vision board or a collage. And then I tell them, start by looking at your vision board every day to be focused. Particularly during the day when you're stuck, and ask yourself, am I living my values? And here is an example of a vision board. I used to bring in like old magazines, and our last session would be people had to create a vision board. You know, by cutting pictures, they could put anything else there, real things like beads or, you know, and three-dimensional things. And that would become the vision board. And I would tell them, display it prominently where you can see it, like put it on your refrigerator, put it over your desk, put it near your bedroom. And the point was to look at the vision board. Start each day by being focused on it. And ask yourself, am I living my values? And you can even state that on your vision board. It is really effective for people who are stuck and who kind of default to their old thinking style. And this is low cost, low barrier intervention. And anyone can do it. You don't need to be QMHP and licensed to encourage someone to create a vision board for their life. And here are some other, this is what I used to do with the magazines. You know, they would cut pictures and create it and all of that. So then goals and actions. This is now, this is not vision board. This is the next thing, is list some of your present behaviors or actions which are designed to enhance your life. What are some things you'd like to do more of, or new things? Can you tell me what steps you can take to improve your life? What are some skills you aspire to build for yourself? Planning and getting active. Remember, people are deactivated. Behavioral activation says that it is important to increase your level of activity, even if you don't feel like beginning. Remember that upward spiral that I showed you? Remember that by starting to do things that are important to you, you will start to feel better. In activation, we bypass the sticky problem of motivation by planning your activity and sticking to the plan, even if you don't feel like it. You follow the plan regardless of how you feel. How many of you have worked with clients who say, I just don't feel motivated. I'm just going to wait till I feel better to do this. No, Nirmala, I can't do it now. I'm too tired. I'm too fatigued. Behavioral activation totally bypasses the sticky problem of motivation by saying you act and then you feel later That means you follow the plan. Even if you're feeling lousy, you get up and do it, whatever you have committed to. And by the way, I'm making it real simple. There's lots of science around this and evidence. So you increase activity from the outside. You follow a written plan, which is an activity schedule, by the way, which we do in Pearls. You monitor the progress. You highlight consequences of how you feel because you followed the plan. And ask for help to stick to your plan. We talk about SMART goals, that, you don't do some pie in the sky kind of goals, which are not feasible, which you can't do. They have to be really practical and realistic. And this is kind of a nice template to use, SMART goals: specific, measurable, attainable, realistic, and time-based. And you can even share this with your older adults in a group setting. Here, you're just recruiting, who can you ask for help to help you stick to your plan? Because remember, people are very demotivated when they're depressed. I'm going to skip some of these things. Enhancing motivation. What do you think will happen to you without changing your life? How would your life be affected if this problem went away? What's going to get in the way of you doing this? What are the costs and benefits of doing this? How are you going to remind yourself to do this? These are all like questions to enhance that motivation. Remember, we talked about self-efficacy, which really means that inner sense that I am capable of doing it. Tell me about a time when you made changes in your life. How did you do it? What personal strengths do you have that will help you succeed? I always used to tell my clients, let's build a brand. Like, who are you? Tell me what your strengths are. What encourages and inspires you? Who could offer support to you? Remember, we talked about increasing healthy behaviors, decrease depressed behaviors, and positive experience result in improved moods and thoughts. Very simple. We've already talked about how typically depressed people wait to feel motivated. In behavioral activation, we say, don't just talk, do. Do means do the action. Let's not just sit down and talk about, oh my gosh, I feel miserable. We are saying, get up and do. And then we can talk about how you feel. Oh, I'm giving some ideas about how to create an activity plan. But if you want to know more about that, our older adult specialists can certainly help you and send you resources if you're interested. And then, there's a whole training on behavioral activation or on Pearls if you're interested. So I'm not, I'm not going to go over this, except that it's an absolutely efficacious intervention for older adults, behavioral activation, which Pearls is about. Okay, so what happens when your client refuses help? Remember the stages of change. These are the 5 stages of change. Why are people afraid? It's not because they're lazy or they're stuck or they just don't care. They're ambivalent about change. They're afraid about changing how they feel because they don't know what's going to happen. That's what this really highlights, is ambivalence. And how do you change that? Have you ever done this with your client? Like, where is your client on these stages of change? Yes, it was built originally for substance use, but it can be used for anything. And then there are specific tools that you can use at each of these stages. And there's a whole different training on this, on just how to use the stages of change. And if you're interested, you can definitely contact your OABHI team. Basically, This model really looks to assess an individual's readiness to act on new and healthy behaviors. And that behavior is seen as a dynamic process, which goes through these changes, not in a linear fashion. You can go back and forth on these 5 stages of change. So elicit attitudes, beliefs, knowledge, having people state their own goals and the way they accomplish goal will help them own the goals. Instead of you telling them, you do this, if they elicit, hey, this is what I want to do, this is what I'm committing to, it's more likely that they will do it, and that we are building that sense of, of capability or self-efficacy. Questions to evoke change talk. What would be the good thing about changing? What would your life be 3 years from now if you changed your problem? Why do you think others are concerned about you? If questions to ask if your client is having difficulty, how can I help you get past this, past some of the difficulty you're experiencing? If you decide to change, what would you have to do to make that happen? I love that question. I used to ask that a lot. If you decide to change, what would it take for it to happen? If your client has little desire to change, suppose you don't change, what might be the worst that might happen? I've had clients say, I'll die. What is the best thing you could imagine that could result from changing? And here are a mix of tools that I have used. One, remember we talked about avoidance and rumination? Remember, and this you're teaching it to your clients. It's a skill. Remember, avoidance can have a short payoff, but a long-term price. Short term, you'll get some stress relief, but long term, it doesn't solve the problem. And we talk in behavioral activation about a negative trap. And so it's really important to understand avoidance in depression. And I don't think many of us do a good job working with our clients around this. Avoidance begins as a natural response to distress. We don't want to feel bad, so we avoid the situation. And guess what? We get some relief, correct? We avoid because it feels better in the short term, even though we know in the long term it's not solving any problem. So it actually plays like a protective role. What does avoidance look like? Procrastination, brooding, bursting, just blowing up at people, hibernating, just shutting down and withdrawing. That's how avoidance looks like in depression. And so what behavioral activation teaches is that what is a depression trap? And the trap is trigger response avoidance pattern. Every day we are presented with opportunities to activate, to do things that matter to us. Remember, with our values, things that we enjoy. Traps are situations in which we are likely to choose withdrawal, escape, and procrastination options, which take us in the direction of depression. Can you see? You have an opportunity to choose. You can either use red, withdraw, escape, procrastinate, or if we teach you the skills, you can go the route of the green arrow, activate things to do things that matter to you. And we are teaching this to our clients or to our older adults in a psychoeducation class. The other one is track. Becoming aware of our trap patterns is the first step. The next step is to get back on track, TRAC. Again, the word suggests a direction. So track is trigger response alternative coping. Remember, depressed people with default go the route of the red arrow, which is avoidance. We are teaching them to go and the green arrow, which is, kind of the universal color for go, like traffic lights. And that is, what is your alternative coping? So teaching people about a trap and track. Here, I don't know how many of you use the readiness ruler. I used to use it constantly in my work when I was a therapist. And it's very simple. A readiness ruler basically tells you willingness to change, confidence in your ability to change, and it's a matter of priority. It's literally like a ruler. You can create a ruler, you can download this, whatever you want, and you ask your person to rate it. What changes are you considering? How important is this to make this change? How confident are you that you're going to make this change? And how ready are you to make this change? I personally am using this readiness ruler right now in my life. I've said yes to the top 3. I'm still struggling with the last one. How ready are you to make this change? Because it involves something active that I have to do. Building confidence. Remember, people who are depressed and deactivated lack self-efficacy confidence. That's their default. So you as a coach, review past successes, define small steps, problem solve. That's what we teach in Pearls. Provide tools, skills, and strategies. This is the confidence ruler. The first one was readiness. This is confidence. On a scale of 1 to 10, how important it is for you right now to change? If the person says 3, then you as a coach or a therapist will say, I see 3. Why did you not choose 1? Or what would it take for you to choose 6? And then on a scale of 1 to 10, how confident are you that you could make this change? Similar scaling questions you ask. And then we've talked a lot about action plans because people who are deactivated suffer from inertia. They feel discouraged. They have all of those negative self-talk, which prevents them from actually being active. They have anhedonia. And so I'm not going to go over an action plan, but it's actually a written action plan. And again, we have fabulous Pearls coaches in our audience. If you're interested, do contact them. And Angela Franklin, please let people know, in your link, both Susan and you do that, RV Cog. So remember I talked about the stages of change. And one of the tools we use in that first stage is resolving ambivalence, is what I call the decisional balance sheet. It's a very simple tool, but very powerful, where you have this sheet with 4 quadrants. And top it says present, future. Side it says strain and pain and gain and growth. What is the current situation costing you? It has cost me my marriage. My children no longer talk to me. My employer has put me on a work plan. I'm just talking out loud here, okay? Question 2. So the future, what challenges will you face to make the change? I'll have to stretch myself. I'll have to go beyond my comfort zone. I may have to go and get therapy, whatever. Number 3, how are you benefiting from the current situation? I don't need to make any changes. I'm comfortable in my misery. I don't have to challenge myself. I can just sleep all day and just avoid my worries. What can you gain by making the changes, and how important is it to you? I may feel better about myself. Maybe I could mend my marriage. My kids may talk to me again. I can get active in my church. Or I can be a valuable team member. Or I can go back to volunteering. So can you see how powerful this is? I use it all the time, and I even use it now in some of my complex case consultations. And this is easily downloadable. Just Google it. It's called the decisional balance sheet. The other one I used to do is the headstone set. Your name, died, your mark on the world, your mission with others. What would you put on your headstone? What would others put on your headstone? It's really looking at that values question. How will people remember you? I love this feeding the hungry tiger metaphor. This is really about anxiety and depression. Because of time, I'm not going to go through it, but it's really, ACT is full of metaphors. It's part of therapy. I would highly recommend you read this, the hungry tiger metaphor. This is absolutely a wonderful skill, which I have used personally and also with others. It comes out of DBT, dialectic behavior therapy. It's called opposites action skill. All emotions activate us to respond, and the type of activation is biologically wired. The opposite action skill allows us to choose to respond opposite from what our response would be. They get us ready to act. Remember, we talked about trap and track, how you default to the red arrow, but we are saying default to the to the green. This is what opposite action is. Do the opposite of what your default is. Thirst. It activates us to drink water, correct? Hunger, it tells us we should eat. Fatigue, it tells us to sleep. Now, here is what opposite action is. Anger, it gets us ready to attack or defend. Opposite would be show kindness or concern or walk away. Shame, you get ready to hide. You want to isolate. Opposite is have good eye contact, put your shoulders back, raise your head, and go into the situation. Depression, we want to be inactive. We want to avoid. Opposite action is get ready. Get activated, get active, follow your plan. So these are all situations I'm giving you. Remember, for opposite action, if we want an emotion to stick around or increase, continue to do the action as above. If we want an emotion to go away, become less uncomfortable, do the opposite of that action. And if we want the skill to work, we must use opposite action all the way and believe that it will work. And this is straight out of DBT, by the way. And here's a really nice workflow, like a flow of how you use opposite action. I would highly recommend you to use this personally and in your psychoeducation classes with older adults and with any adults for that matter. And you don't have to be in DBT to do this. So again, I've given lots of stuff on opposite action because I so very much like it. Yeah. So here are some examples of how you can use it. The other DBT skill that I love to use is called the IMPROVE skill, which is an acronym, which stands for imagery, meaning, prayer, relaxation, one vacation, encouragement. For example, imagery, improve the moment with imagery. Imagine a beautiful scene on the beach or in the mountains. Imagine a safe place in your home. So you're actually teaching this skill to older adults or any adults for that matter, that they can use in a moment of emotional distress, called the IMPROVE skill. Key messages, the emotion regulation module in DBT is devoted to helping clients reduce sensitivity to emotions and vulnerability to stress. It helps to build resiliency to stress that can be improved by doing, all of these other things and practicing emotion regulation skills, and the opposite action to emotion and building positive experience skills are useful in managing depression and improving interpersonal communication. I also say create a rescue package to have with you. We all have these rescue packs or safety packs in a car in case of bad weather. Create an emotional rescue pack. Help your clients create that. When they are distressed, what are some phrases they can use? I can get through this. This will pass. I have friends who can help me. Activities, what can you do in the moment when you're very distressed? Or sensory. Maybe it's music. Maybe it is some anchoring object or a touchstone that you have. So actually help your clients create a rescue pack. Then there is the miracle question. This comes out of solution-focused therapy. Feeling stuck? If you're looking for a way to get out of a rut or how to make a difficult decision, and you're looking for inspiration, then ask the miracle question. Suppose tonight while you slept, a miracle occurred. When you awake tomorrow, what would be some of the things you will notice that would tell you your life has suddenly gotten better? This question is a goal-setting question that is useful when a client simply doesn't know what the preferred future looks like. And by the way, there's a lot of science behind this. Again, it is solution-focused therapy. The miracle question catapults the client from a problem-saturated context, because that's the default on depression, into a visionary context where he or she has a moment of freedom to step out of their problem narrative into a story where they are problem-free. And here are some ways that you can ask this question to your client, and I'm not going to go over it, but it's there in my slide deck. Okay, and then there are some follow-ups. How will you know the miracle has happened? What will others notice about you? How would they react? What would you do next? Again, this talk was about difficult clients, how we feel burnt out and not professionally gratified. So really understanding secondary traumatic stress and burnout, very important. And I'm hoping all your organizations actually have that as a policy. And if you're interested in a training on burnout and traumatic stress, please let your older adult specialist know. And they're encouraging organizations to focus on staff wellness, especially when we work with difficult clients and with large caseloads. I am a big proponent of something called reflective supervision, and I actually give a full 2-hour training mostly for managers, but also for people who practice in whatever capacity, on what is reflective practice, because I never got reflective supervision when I was a clinician. And I can see how beneficial it is. Here are some screening tools, which many of you may know of. I would also, for older adults, I would add a pain assessment. And I know your next speaker is going to be on pain. And by the way, Dr. Draco is fabulous. You will love her. So pain. And then we also have another scale called mini suffering state exam, where you're having like suffering, physical suffering, which could also include psychological suffering, especially for older adults who are maybe at the end of life. Reflection, my last question to all of you. How will you change your practice? And what is one intervention you will use to work with your stuck clients? Here is all of the stuff that I based my work on today. And thank you again. And I am going to stop sharing. I know I covered a ton of information from bits and pieces from several modalities, but the crux was really having compassion and understanding about why your clients are stuck and what are some helpful ways for you to really get them unstuck. Thank you. And Janine, I don't know whether there was anything in chat or in questions.
Yes, here's one from Cheryl. As we age, connections decrease and life shrinks, making distractions from repetitive and automatic thoughts more difficult. How do we reach those who don't seek services or continue to avoid connections?
Yep. And that's a huge question, Cheryl. Thanks for asking that question, though. Through the Older Adult Behavioral Health Initiative, we are doing a ton of work around social isolation and loneliness. In fact, I met with both of the specialists from Josephine County yesterday, and we actually talked about that. You know, what can we do in Josephine County to really promote social connection among older adults? So, that's a huge question to answer. If you send me an email, I would be very happy to address it with you. But it's absolutely true that social isolation and loneliness actually augments as we age. But overall, if you look, older adults are more happy and satisfied than younger age cohorts. So what are some lessons we can learn from those people who are, aging successfully that we can apply maybe to the rest of our aging friends? So, but it's a much bigger question, but thank you for asking that.
And then Diana has commented, tough part is when folks no longer have the physical ability to do the things they like, and that it's a huge barrier.
And that is a critique of activation, but really looking at what are some substitute activities, so really working, hard to explore that with them. There are sometimes mobility issues. There could be some mild cognitive issues that come in the way. There could be, pain, all of that. Absolutely, that hinders what you were able to do. And yes, that is a critique of behavioral of activation in general for older adults, but it is still very efficacious with older adults. It takes a little bit more work in exploring and maybe adapting activities.
And then Matthew commented, I like the mirror example. When I was working directly with clients, I would tell them, look in the mirror and tell the mirror what you want to happen until it's manifested.
Absolutely. And I can't emphasize the vision board exercise too. It's very simple. It's very low key, low cost. It's a simple activity that you can even do in a senior center. Let's create a vision board of what you want your life to look like for the next 5 years.
I also want to say that if people want to raise their hand, you can unmute yourself when we call on you and ask Nirmala directly a question if there are any.
Or even a comment if you have, yeah.
Yeah.
And there is a comment, forgive me if I'm pronouncing the name wrong, Lael. Are county buildings like libraries an area that could help support connection for older adults? And yes, we do quite a bit of programming in libraries.
Absolutely. I'm so glad whoever it is who brought that up. I know Janine, for example, does work in libraries. So we have work with libraries happening all over Oregon. In fact, one of our specialists recently spoke at a Oregon-wide conference of libraries on the memory and age cafes that they're offering in libraries.
And then Rachel asked if Cheryl's question could be included in the email, our follow-up email. So
you mean the response?
Yes.
Yeah. So I would need to have that question, Janine, if y'all can send it to me in some way. So absolutely. Well, my hope is that I've added some new skills for you in your toolbox as you work in whatever roles you have, a better understanding about why people get stuck, and because of depression, and then what what can you do, in terms of using any of the skills to move people into a new way of thinking and acting. And then very important that all of you, work. I call our work emotional labor, and that absolutely, it's undoubtedly affects us. It's a human response, correct? Whether it is working with difficult patients or clients, and where every day you see pain and kind of misery, right? It is bound to affect us. I mean, that's only human. That you address that at an organizational level with your supervisors and your teams in terms of what are they offering you in terms of wellness for all of you who work in this field, because we want a robust workforce, and we don't want people leaving this because they're not getting the support they want. And partly this is one way that we are offering support, where we are offering trainings and skills that you feel empowered that, hey, I know what to use or do with some of my clients. I can't tell you how important that improved skill is. I don't know how many times I have really advocated, have you used the improved skill? The other day I was talking to some palliative care social workers who had called me, Nirmala, what do we do with, my cancer clients? I said, teach them the improved skill, and which they're going to now. Yeah.
Well, thank you, Nirmala, so much. Angela Jensen is gonna close us out.
Yes. Thanks. It's always a joy to hear from Nirmala. She never gives us a data dump. There's always practical solutions and recommendations included in her presentation. So we really appreciate that we were able to grab you for a couple of hours today. I'm sure many of you are wondering, will you get the PowerPoint? Yes, you will. And you will also receive a follow-up email with links to surveys and all materials, any handouts that Nirmala might want to add to her PowerPoint. Give us a couple of weeks to get that to you. If you need just a certificate of attendance, you have to complete the PSU survey. That's the only way you get the certificate of attendance. We suggest everyone do that for us. It helps us justify to the state our existence, that we're out here doing work. So help us out, please. And for claiming the 2 CEUs that you get for today, you've got to do the NASW survey. Most of you are familiar with that. If you don't know what I'm talking about, reach out to me and I will help you with that. But all materials will be coming towards you in the next couple of weeks. And please join us. Golly, is it just 8 days away? Yes, it is. Chronic pain and medication misuse among older adults with Dr. Katie Drago. That one also comes with 2 CEUs. So does Nirmala's PTSD in the older adult, June 6th, 9 to 11. All of these will be brought to you in our new and improved webinar format, which we will figure out the chat issues amongst other things. Thank you for your patience and your grace with today's technical issues. We'll make sure to have some of those kinks ironed out by the next time you see us. And we hope to see you on the 9th and a month later on June 6th. If there are no other questions, and this would be your time, speak now or forever hold your peace. If there's no other questions, we're going to cut you loose, give you the gift of time, let you move on to your 11 o'clock appointments. Going once, going twice. Okay, well, on that note, folks, thank you. We wish you well, be safe, be kind to yourselves and each other, and we will see you at the next event. Bye-bye.